Hello, everyone. My name is Gunasingha. I am a resident at Walter Reed, and I am presenting in lieu of my colleague, Dr. Sadesh Niroshan, who is a general surgery resident in Sri Lanka. And this is evaluation of the fasciotomies performed during the Sri Lankan Civil War. Okay, I have nothing to disclose. So during any combat injury, people have resulting devastating wounds from them. So soft tissue, vascular, and skeletal injuries can all lead to a high likelihood of developing compartment syndrome. While compartment syndrome is a clinical diagnosis and the need for fasciotomy comes from that, there's a lack of criteria for combat surgeons in performing a prophylactic or early fasciotomy in patients that suffer an injury. So usually the wounded that we deal with and the wounded that was in Sri Lanka travel amongst different echelons of care. There is a low threshold for early fasciotomies, mainly to decrease limb loss as well as mortality as a result of compartment syndrome. From our early U.S. military experience, we found a high rate of incomplete or delayed fasciotomies. But then you could see between 2003 and 2006, early parts of the war, the fasciotomy rates doubled, mainly because that knowledge of the need for early fasciotomy was put out there. Currently, though, there's no algorithm to really predict who needs an early fasciotomy from their injuries. So in this study, we had a prospectively collected trauma registry from one of the vascular surgeons in Sri Lanka over an 8-month period, and all of these included extremity vascular injuries. And the variables that we collected are on the side. And as a background, so the Sri Lankan Civil War went on from 1983 to 2009 and is really an insurgency against the LTTE, or the Liberation Tigers of Tamil Eelam. And this was a fight for the independent Tamil state within Sri Lanka. They were defeated in 2009, but kind of throughout their period of terror, there were suicide bombers, IED landmines, as well as gunshot wounds that were suffered by not only military personnel, but as well as civilians. There are multiple assassination attempts for high political leaders, so the civilians that were in that area suffered injuries as well. They estimate during this time about 80,000 to 100,000 people died as a result of the Civil War. These are some of the pictures from kind of the front that they were fighting in. You can see multiple injuries and how the terrain is very difficult to evacuate these patients. A lot of times they only used land medevacs, and a lot of times it took about 3.5 hours to get patients out to the next level of care. It's the operating room in Sri Lanka. So in the surgeon's registry, there were about 150 patients that he identified. After exclusions for different types of injuries, there were 81 included, which we had lower extremity as well as upper extremity. The lower extremity patients were divided into injuries above the adductor hiatus as well as the below the adductor hiatus. So the average time for transfer to the next echelon of care was about 300 minutes, which is a lot longer than I think we see in our patients. Frequency of the fasciotomies, you definitely saw below the adductor was much higher, and then upper extremity followed by the above adductor hiatus. And this was, again, how frequently they perform fasciotomies in those patients. Really looking at the whole range of fasciotomies performed, an injury below the adductor hiatus, as well as presence of total ischemia, so absence of pulses as well as Doppler signals, were statistically significant for getting a fasciotomy. And then looking at associated fractures, arterial injury severity, associated venous injury, as well as blood transfusions weren't statistically significant in this study, but things that were considered in patients getting fasciotomies. The amputation rate was significantly less if the fasciotomy was performed at a roll 2 prior to versus a roll 3. And again, this would be because these are earlier fasciotomies than not. Amputation rates were higher, about 36%, if they got the fasciotomies in the hospital, and that would indicate like a roll 3, versus in the field, which is roll through, and then versus no fasciotomy, as well as length of stay was longer for the patients that got fasciotomies in the hospital. And we attribute this to the severity of the injury or the delayed nature of the fasciotomy. So in conclusion, I think, based on this experience, the need for any early or prophylactic fasciotomy should be completed for injuries that are below the adductor hiatus, and then those that with total ischemia. Monitoring would be appropriate for the extremity arterial injuries without total ischemia, lack of associated skeletal injuries, and then less than 6 hours of total ischemic time, and then low probability for massive transfusion. And again, you have to be able to reliably monitor these patients, and if they're traveling between different echelons of care, it's probably better to do the prophylactic fasciotomy than not. Again, Dr. Sadesh Niroshan was the primary author on this study, and this is the rest of the team. Thank you, and I'll take any questions.